bringing up beat, hanging with my rude sky brothers in the street. My brother said, oh, you'll say, turn up the box up. There's the jam to rock us all day long. And knock your socks off, says little brother Fishbone. So get off your seats and let's skate to the beat. Hey, Fishbone brothers, let's gang to the beat.
Hi, Martha Roberts here. I wanted to talk to you this month about something a little bit fishy. Now, it's not going to be stinky, but it's going to have to do with fish. And it's not how to take a fish hook out of someone's hand, but a little more suave, taking out a bone from someone's throat while they're still awake. Okay, so here, fishy, fishy, fishy. The skilled ED provider always takes proper precautions before attempting fishbone removal and preparing for patient discharge. But a sensible provider never sends an anxious patient down the river without a thorough exam. So we're going to talk about how to remove a fishbone from a patient's throat. Fishbones are usually slightly waxy, a little bendable, they're sharp. These tiny bones lodge themselves in the throat with a vengeance. Common nesting sites of fishbones include the base of the tongue, tonsils, posterior pharyngeal wall, aryepiglottic fold, or the upper esophagus. Late complications of leftover fishbones in the throat may cause airway obstruction or rarely esophageal perforation. The patient is always at risk for aspiration before and during the procedure of removal. All fishbones should be removed immediately, so there's no delays here. ENT consultation with endoscopy, maybe GI involvement, depending on who wants to argue where the placement of the bone is, may be necessary. And if you're unable to locate or remove the bone itself, you definitely want to consult these guys. The literature is mixed about plain radiographs versus a soft tissue CT of the neck. A CT scan of the neck is warranted if the patient has dysphagia, is bleeding or choking, or has really any other concerning signs or symptoms. So you may consider a CT if the patient has a negative neck X-ray and if his symptoms are severe. Now, not all fishbones are visualized on plain films, so the anxious patient should never be overlooked. The common laryngoscope or fiber optic nasopharyngoscopy, such as the glide scope, are used to assist with this procedure. Now, don't get too excited, all right? We're not going to sedate and intubate this patient. Don't do it. These tools aid in better visualization of the throat and leave less room for error, okay? Now, clearly you're not going to be using these in a pediatric patient that cannot work with you with this difficult removal, or an old demented patient that keeps smacking your hand, all right? These patients need to be able to work with you. Plus, these specific tools are really great for allowing the provider to open and examine the patient's mouth and posterior pharynx with a steady hand while they stabilize their tongue, which is the key to getting these guys out. So we're going to start with the approach, all right? We're going to inspect and image the throat, right? We're going to look for a foreign body, specifically the fishbone, use the laryngoscope or fiber optic glide scope. And then you're going to have these people follow up with ENT. The procedure, pretty straightforward, right? You're going to think about how you want to position the patient first. You don't want them sitting up, unless, of course, they're drooling or coughing, in which case you probably already consulted some specialist. Position the patient in a supine position. Spray their throat with a little local anesthetic, such as a benzocaine. You may want to spray them before they lay down. It depends on the patient comfort if they're already freaking out. You may also use viscous lidocaine. I actually think that works a lot better. Physical exam of the external neck, easy. Check for any point tenderness, any palpable mass, any emphysema or crepitus. It really depends on when they swallowed this bone in the first place. Have the patient open his or her mouth so you can examine the oral cavity and the throat closely using nothing but excellent lighting. If you are not using a good light, you might as well not even attempt this procedure. I have a headlamp. I'm proud of it. I use it, and it's best. So maybe you should invest in one. I don't know. Tongue blades are a must. I know we can never find them, but maybe you can keep a few extra in your pocket. Inspect both the tonsils and the posterior pharynx while attempting to visualize the fishbone. Most patients will be able to tell you where they feel their symptoms. So, oh yeah, it's a little more on the right side, doc. No, it's a little more on the left side. No, wait, I think it's on the right side. Anyway, you get the point. They can usually localize the position of the bone. Order imaging after you have taken a first look. Don't blindly just say, all right, well, we'll send you over for imaging and then we'll check you out later. Well, you may or may not be able to see the bone with just the naked eye. It's time then for the attempted removal, once the imaging has been completed and reviewed, of course. Usually bones that are in the tonsils or posterior tongue can be easily removed in the sitting position or supine position, we recommend supine, with a tongue blade and a hemostat. Place the patient in a supine position and prepare for deep sea fishing if the bone is lower than the tonsils. Use the laryngoscope or fiber optic to examine the patient's throat. Explain to the patient thoroughly what's going to happen. All right, it might be beneficial to do this before you start shoving things down the back of their throat. It is best to tell them to breathe in through their nose and not to swallow. Consider using suction under the tongue to help with the secretions. Patients with hypersensitive gag reflexes may need some additional anesthetic. They might even benefit from a little Ativan. Why don't you pop a little 1 milligram tablet right before they go to x-ray, and by the time they get back, makes things a lot easier. Insert the scope slowly, and inspect. This may take 2 or 3 attempts, so again, go slowly and keep your body low as you inspect internally. You should basically be in the intubation position, but you've got to fight the urge. Don't intubate them. If you see that fishbone, target them and grab them with your hemostat. If you can get it on the first try, that's even better because then the patient has fewer times to react to you jumping down their throat. Note that strands of saliva may mimic a bone. Have the patient swallow several times after removal. They should immediately experience relief if the bone has been removed. The patient may return to a regular diet to solid foods immediately. Have them follow up with an ENT in 24 to 48 hours if they continue to have symptoms. Repeat films are not indicated unless there's strong suspicion for multiple fish bones. That's going to put you in a tricky situation. The patient should experience immediate relief if a bone is successfully removed. Do not send the patient home with solutions of viscous lidocaine. This can be toxic in large doses. Should never exceed 300 milligrams in 24 hours. Only about 20 to 30% of patients with a sensation of retained fishbone will actually have one. But you must take this complaint seriously and consider a bone present until proven otherwise. Most bones get caught in the oral, hypopharynx, or rarely pass into the distal esophagus. So that means they're pretty much going to be visible to you on direct vision, except when, they're not. But if they're in the base of the tongue or the tonsils, you should be able to see these guys. No specific sign or symptom will consistently rule in or rule out a retained bone. Patients can generally localize the position of the foreign body, as we already suggested. Again, caution, lateral neck x-rays, they're of little clinical value in most patients with minor symptoms, so a CT scan is probably the best test to order if any additional investigation is required. The patient can be discharged to eat normally, again, in 24 to 48 hours, but they need to get that recheck. One of the interesting things you need to keep in mind is that fish bones impacted in the esophagus perforate. They don't dissolve. So you have to get them out. It's really unlikely for a bone to perforate the stomach lining once it's swallowed, so you can assure patients that if for some reason you're trying to fish for it, you lose it, and they swallow it, they're not going to give birth to a fish or perforate their abdomen. Be sure to review signs and symptoms of perforation, though, just in case. I gotta hand it to my buddy Dan Hermes. He's one of the most fabulous attendings I have ever worked with just because he is just the most laid-back, go-for-it kind of guy. He and I used to work triage shifts out in the pit, and I gotta tell you, one day we had 3 fishbone patients sign into triage. It was a crazy day. I think we saw volumes over 300 that day. But between the 2 of us, we were able to throw some laryngoscopes down these people, and we actually removed 2 out of the 3 bones. We were high-fiving each other like nobody's business. So you'll get a good day like this, and that feels really good. But I gotta tell you, his favorite thing is the glide scope. He uses that every time. It's so much easier to do your visualization, and if you go gently and slowly and use the right anesthetic, this is such an easy procedure to do. I promise you. The thing that he always wanted to do, though, was make sure that the stretcher is positioned at the right height, so all you tall bees, don't have to bend over and break your back, because he's a tall guy. So, with all that being said, anytime these patients sign in, take them seriously, think about what's going on, and if you need additional tests or any kind of specialty referral, get on the ball quickly, because these patients have trophies to be won. Until next time, this was a procedural pause.